I'm going to talk to you over the next 45 minutes or so about gastroesophageal reflux disease and heartburn, and also some of the sort of long-term effects that having that can have in terms of complications. And particularly, I'm going to spend a little bit of time talking about a condition called Barrett's esophagus. Okay, so just out of curiosity, how many of you ever heard of the word Barrett's esophagus? Okay, all right, so most of you have heard of it. So we're going to talk a little bit about that. So I'm going to sort of spend about 30 minutes maybe talking about reflux and maybe about 15 minutes about Barrett's. Okay, and then we'll have some time for questions at the end. Okay, so the first thing is heartburn is a symptom. So, it's not really a disease. Heartburn is just what you feel. It feels like the center of your chest is on fire. That's where your heart was. So that's basically where they say, well, it's heartburn. Okay, but it's actually not the condition. And there are other things that can give you those exact sort of symptoms. Okay, so GERD is actually the condition. Well, what is GERD? GERD is gastroesophageal reflux disease. Okay, and that's what GERD. And that's really a condition where you have contents from the stomach coming back up into the food pipe, which is the esophagus that connects the mouth to the stomach. And that can cause a variety of symptoms, sometimes discomfort, it can cause pain, and it can cause a sense of just a feeling of a bad taste in your mouth, and actually it can cause a variety of other things, which I'll talk to. So heartburn is a symptom, GERD is actually the medical condition. So there's really sort of a couple of different kinds of spectrums of this sort of condition of GERD. You could be like the gentleman on the left who really complains of heartburn occasionally, just once or twice a month, intermittently, maybe associated with some dietary indiscretions, and we'll talk about what they are. So in his case, it's carbonated beverages and maybe somewhat of a little bit of a greasier meal. Okay. And he gets relief with just over-the-counter stuff like Tums or Rolaids or those kinds of things that you'd see, so antacids. And then the person on the left has a little bit more serious version. It's not just once or twice a month, it's every day. And gets relief with over-the-counter medications, and pretty much every class of medication now, for the most part, is over-the-counter. There's a couple that there aren't, but most of the medications that we use to treat acid are actually available without a doctor's prescription now. And he's had symptoms for a much longer period of time, and it's becoming more frequent. And so we'll talk about sort of the difference in spectrum between those two people and what it means. So it's a common condition. Basically, 1 out of 2 people in this country is going to have these symptoms of GERD, okay, once a month. So it's really a huge problem, okay, and I'll get to just how big in a minute. And 1 in 5, or 20%, has symptoms at least once a week, okay? And this actually, their studies have shown, can cost, based on lack of productivity, lost days due to work, a variety of other things. It has a significant impact, about $3,000 per employee annually. And it's not really the cost of the medications, it's actually the cost of how this impacts your life and your productivity, okay? So one thing before I start, because one of the talk is it heartburn or something else, right? So I would always mention that if you're having chest pain, particularly if you have symptoms that go to your arm, particularly your left arm more than your right, up into your neck or into your jaw, a burning in your throat that's severe, that isn't relieved by sort of the medications that we're going to talk about, symptoms particularly if they get worse when you exercise, if you're associated with a lot of shortness of breath or fatigue, those are all very concerning signs for it actually being your heart. And certainly if you're having this, usually the most important thing initially is to make sure that it's not that. So if you're having any of these types of symptoms as well, along with what you think is GERD, I would certainly tell your primary care doctor and have you see a cardiologist or a heart doctor to discuss whether additional testing is needed. Okay, so that's very important. Okay, so hopefully you're not having those symptoms, and so we'll assume that you have something that we think is likely to be GERD or heartburn symptoms. And so we'll talk a little bit about how common it is, how does it feel, why do we get it, and again, I've sort of gone over that a little bit. Monthly, I said it's again, on a weekly basis, it's about 20%. Daily, it's about 10, and as I mentioned, more than half of people will have it at least once a month. It affects, significant symptoms affect up to 60 million Americans. More than 15 million have a diagnosis of GERD. But the thing is that this is one of those things where the majority of people don't see a doctor. They sort of suffer on their own or just self-medicate with Tums or other sorts of things. There's a lot of, you don't actually need to see a doctor for this these days because you can often get the medicine. You see it advertised direct to consumers all the time, the purple pill. You see all these things on TV pretty constantly, right? But that doesn't mean you shouldn't see a doctor, and we'll talk about when you may benefit from actually seeing a physician about your reflux symptoms. And actually, studies have shown that this can really affect your life. It can affect it as worse than ulcers, angina, high blood pressure, or even menopause. So it can carry significant effects. At least 20% of the population in this country takes medicines twice a week for GERD symptoms. There was over 100 million prescriptions written in 1998. There's probably less prescriptions now because, like I said, it's mostly over the counter. And in 2009, this is the most common reason people visit a GI doctor like myself. So if you say, what's the most common reason somebody visits a GI doctor? It's basically for heartburn and GERD symptoms, more than any other symptom that's out there. It's also the most common reason that people get an upper endoscopy. That is a scope or camera that's put down the mouth to look at the esophagus, stomach, and duodenum. Okay. So 8.8 million office visits, 65,000 admissions related to GERD or complications of GERD. And again, there's a variety of medicines. Say, well, I don't really need to see you. I just take Tums. Well, that's great. If Tums are working for you or antacids, you're in the lucky few. It's 20% of people will actually respond to that. Okay, so 4 in 5, that won't be enough. If you take these other medicines like Tagamet or Pepcid, you've probably heard of those kind of medicines. Those are kind of intermediate strength. Okay, they don't work quite as fast as a antacid, but they're a little bit more powerful. Okay, and they work in about half of patients. And then there are medicines like the purple pill or all these PPI medications. These are the omeprazoles, the Nexiums, Previcids, Protonics, those sorts of medications. And those medicines are highly effective when taken appropriately. The problem is a lot of times patients don't know exactly how to take them. And one of the things I'll talk about today is exactly how to do that. Okay? So these are the classes of medicines that are there. Now, why do I get this, right? So there's a whole bunch of reasons, but the two biggest reasons are there's a muscle that sort of separates your food pipe, the esophagus, from the stomach. And that muscle is supposed to stay shut or sort of squeeze tight and only really relax for the most part when you swallow. And it sort of relaxes to allow sort of the food to go through. I always sort of say the analogy is if you've ever had a little bit of toothpaste at the end of your toothpaste tube and you got to kind of coordinate it to squeeze it out, that's kind of the way the esophagus kind of gets that food that you swallow down in. And so if it doesn't coordinate right, or if the end of that thing is plugged because the muscle won't relax or relaxes too much, you tend to get backwash. And that's the problem, is this muscle is oftentimes either loose or it relaxes too much. And as a result of that, there's free backwash of stomach contents up here. This is really supposed to kind of be one way from north to south, but it can tend to go back up the other way, and that's when you get this. So that's either due to either a sort of a weakened or loose muscle, or a muscle that for whatever reason is relaxing, at times that it's not supposed to. There are other conditions. People often talk about hiatal hernias. It's a little bit of your stomach that's squeezed through this hole in the diaphragm. So technically your stomach is supposed to be in the abdomen, which is below the diaphragm, and the esophagus is in the chest, which is above the diaphragm, and they're not supposed to mix, but sometimes a little bit of stomach squeezes into the chest, and that's called a hiatal hernia. And so people will often say, oh, my hiatal hernia is killing me, okay? And I'll tell you, hiatal hernias in and of themselves don't do anything, okay? It's not like an inguinal hernia, it's not like another, they don't cause symptoms, okay? Other than the fact that people with hiatal hernias are more likely to get reflux. And it's the reflux that's giving you the symptoms, not the hiatal hernia. So people often say it's my hernia. It's like, well, indirectly, it's your reflux, which is in part due to having a hernia. So normally what happens is that the diaphragm serves as a belt. So it's sort of, we always talk about sort of the old belt and suspenders, kind of a double protected system. So normally right at where that valve is sort of closing is also where the diaphragm pinches. So you've got the muscle, and then you've got the diaphragm also pinching there to sort of give a little extra support to try to prevent the acid from going up. When you have a hernia, where that belt is not lined up with the muscle. It's actually at a different level. And rather than working together, they're working against each other, which is why you tend to get reflux. Okay? So that's why. So people with hiatal hernias are more likely to get reflux. Reflux often causes symptoms, and that's what sort of bothers patients. There's a few other conditions. There's some rare conditions. Our mouth makes saliva, which actually is a base. It helps neutralize acid, and some people don't make enough saliva because they have certain conditions that don't do that. And so that can also impair their ability to clear the acid or neutralize the acid, and that can sometimes lead to symptoms. Some people don't have a good mechanism. I told you kind of have to squeeze like a toothpaste tube down to get the food down the esophagus. Some people, that mechanism doesn't work well, so when they get backwash, they don't clear it very well, and then they get more exposure to the acid and longer time, and that hurts more. And some people's stomach don't empty very well, so if it doesn't go forward, it just kind of sits there, and it's more likely to go backwards, okay? So there's a whole bunch of different things, and we can test for which of these things that you have, but the most common two are I have a loose valve or my valve relaxes when it isn't supposed to. That's really the majority of people. Okay, so why do you get reflux? Well, there's some physical things, and then there's things that we do to ourselves, okay? So if you're somewhat obese, you've got a sort of a big central abdomen that causes more pressure on the stomach. That makes things more likely to go up. As I mentioned, some people have delayed emptying of the stomach, which means the food sits in the stomach longer than it should, and it's more likely to go up. Obviously, pregnancy is a little bit like being obese in the sense that you've got another person in you, and so that's actually causing compression of the stomach, and that's actually going to cause increase of reflux. There's certain conditions that sort of make the esophageal motility not as good, so that causes that. I told you why a hernia causes it. And of course, if gravity is not helping you, if you're lying down, you don't have gravity to help you, right? Because gravity, when you're standing up, everything wants to go down into the stomach. But when you're lying down at night, everything's flat, and things in the stomach can more easily come back up into the chest, right? So now, what are the things we do to ourselves? It turns out that when you smoke, you end up lowering that valve pressure. So smoking ends up being one of the things. Smoking's got a lot of negatives. That's one of them. Alcohol use is another. It actually causes, again, sort of weakening of that valve pressure. There are certain medicines, particularly blood pressure medicines. If you're on theophylline, which is a medicine some people have used for lung disease, asthma, that could also be another thing that lowers that pressure. If you eat a big meal right before you go to bed, your stomach is full, it stretches, and so that puts a lot of pressure on that valve to stay shut because it's being stretched open, and that tends to make you get a little bit more reflux. And then certain foods, chocolate, coffee, peppermint, fatty foods. So it's not uncommon. You go out to a big fancy dinner, right? You have a nice big steak, it's a fatty meal. Maybe you have a coffee with your chocolate dessert and maybe a glass of wine with that. So boom, you're sort of stacking all these things on together. Then you go home and you lie down at night, right? So you sort of stack these things on. So that's why people tend to get some of these symptoms. Okay, so the typical symptoms that you get are heartburn, which is the burning, or regurgitation, which is, some people say, well, Jock, when I bend over to kind of tie my shoes, I feel stuff coming up into my throat. I feel it in the back of my throat. I mean, I feel like I'm vomiting, but I'm not vomiting. I can just feel all that liquid, and I hate that, right? So that's regurgitation, okay? So, and then there's other things that you can get. Sometimes it doesn't feel like a burn. It's a different kind of pain, and then people wonder, is it your heart? Is it other? So you can get some kinds of atypical chest pain as well. But sometimes the acid can not only just go, or the contents of the stomach, primarily the acid, but there's other things we think that are cause irritation. Not only does it just go into the food pipe, but it goes all the way up into the throat, okay? And that can cause a variety of symptoms, and you can actually get it into the lung. And so we've seen people it's actually a common cause of adult asthma, bronchitis, pneumonias, a variety of other conditions, some even as severe as pulmonary fibrosis, and certainly other conditions that give you a sore throat, a hoarse voice. That can all be from acid coming up back at night. We've even seen people who've got sort of loss of their teeth, the dental, because they've got the acid working at night on their teeth, and that actually causes some tooth damage. It can lead to bad breath. It can lead to a sense of fullness in your throat. Some people say, Doctor, I always feel like there's something caught in my throat. I can't seem to clear it no matter how much I cough or other things. and that's sometimes associated with this as well. So it doesn't always have to be heartburn, and acid reflux or GE reflux can often be leading to one of these other symptoms. So if you're having a lot of these other problems and no one can figure it out, if you're also having reflux, particularly if that reflux isn't under good control, you might want to try treating your reflux better and see if some of these symptoms might get better as well. Okay, GERD and asthma. Asthma is the most common lung symptom of reflux. It's present, about 1 in 3 to as many as 90% of patients with asthma will actually have GERD. And only about half of these patients are going to have symptoms of GERD, and only a quarter will actually have evidence of damage to the esophagus when you look at it with a scope. So it's hard to prove. You might say, well, gee, how do you know if you scope them and it looks normal, and if they don't have symptoms, how do you know it's GERD? And it turns out we actually have ways of putting probes in your esophagus or your food pipe here that can actually measure the acid, and we can tell you if you're having acid or not, whether you feel it or not. Okay, so we actually have ways to do that. And the other way you can do it sometimes is just treat yourself. Maybe you say, well, I don't want to do all these tests. I don't want to have all these tests done. You could just treat yourself with the medication and see if you get better, and that's another way to potentially do it as well. So we'll talk about how do you treat this. So we know what it is, we know the symptoms, we know a little bit about why you get it, but most importantly, how do you treat it? Like, how do you make it go away? Okay, so well, the first thing that we used to say was, well, you got to change your lifestyle. Don't eat big meals to stretch the stomach. Don't eat right before you go to bed because you're lying down after making your stomach full. Obviously, tobacco and alcohol, which lower the valve pressure, avoid those. Basically, I showed you that list of things that can cause it. Just try not to do those things, okay? The problem is that even if you do all these things, it doesn't always work. And so, I've got some people who are marathon runners who have bad reflux. You can't tell them to lose weight. They're not heavy. They're not, so it's not always, certainly some of these things will help. But, and also doing these things, especially if you're saying, well, tell them to lose weight, that takes time, and if you're having problems every night, you want something to fix you right now, not in 30 or 60 days when you've lost some weight. So, again, this isn't usually what we recommend. It certainly probably long-term may help you avoid needing medications, potentially. But most of the time, we start more aggressively. And so, like I said, you can start with antacids. These are the Tums Rolaids. They work really fast, but they're not that powerful. So if they work for you, great. Consider yourself lucky, but it's only going to work in about 1 in 5 people. Then I told you these intermediate type medicines work in about half. The PPIs are the best. They work in about 85 to 90%. There are certain other drugs that actually help the esophagus squeeze better, so it sweeps forward better so that there's less backwash and time in contact. There are certain endoscopic things that we can do, little procedures that we can do through the scope that can do. Unfortunately, most of those haven't panned out too well. And of course, you could have one of several types of anti-reflux surgeries, which often are really just an overnight procedure now. Okay, so I'm going to sort of tell you an important thing that most people are on these PPI medications because, frankly, that's the best drug. And I'm going to tell you a little bit about this, and the reason I'm getting into this detail is probably the most useful thing I'll tell you about tonight is how to take your medicines right, because most of the time your doctor may not have told you or haven't had the time to tell you, or maybe they just told you wrong, but some folks don't know this. But this is the cell that makes the acid in your stomach. It's actually located in the top part of your stomach, okay? It's called a parietal cell. And basically, you can think of it as a factory that makes acid, okay? And it's got 3 inputs. So imagine in the front of the factory, there's 3 mailboxes that take orders for acid. One's called gastrin, that's a hormone. One's called acetylcholine, that's a neurotransmitter, and one's called histamine, okay, which is, it's basically a cytokine, it's a receptor, to a certain type of molecule. So any one of these 3 can stimulate acid, okay? And so there are some medicines, like those Tagamets and other types of medicines, they basically block this. And so you can't really get this to activate. But still, other techniques will work, and you can still make acid. So rather than, and if you take an antacid, all it does is it doesn't stop the acid production. it's basically like pouring cold water on top of hot just to make it neutral, okay? So it works right on the top. If your hand is really hot and you pour cold water, it feels better right away, but it doesn't stop the fact that the hot water was there in the first place, right? So the question is, how do I stop the acid? And the best way to do it is to block these pumps that actually make the acid. And that's why they're called PPIs. They're called proton pump inhibitors. And so this here, this little pink thing, is actually the proton pump. And the proton here is the hydrogen here, and that's actually what makes the acid. And this medicine goes in and blocks these permanently, okay? Well, if you say, well, if it blocks it permanently, why do I have to keep taking the medicines? And the reason is because you keep making new ones, right? So you block this one, but your body makes new ones, and then you got to take it the next day to block the new ones it made, and so on and so forth, okay? So basically, the reason the PPIs work the best is it blocks no matter, as I sort of say, this is like taking down one of the mailboxes, but basically, if you take a PPI, it's like blowing up the factory, so the whole thing doesn't work now, right? So you can't use it. So that's really, I think, the best technique, and the best drug for treating it. So in the old days, we used to say, well, why don't you just try to lose some weight, and if that doesn't work, we'll give you a little better drug, and if that doesn't work, we'll give you the best drug. And the other way, we could say, well, why don't you give me the best thing right now, and if that works, once I feel better, I'll dial it down, so maybe then while I'm losing weight, I'll be feeling good, and maybe I can go down to H2 blockers, and then maybe I'll go down to lifestyle modifications. And so the original reason that we did this sort of let's go less to higher was because the drugs were really expensive back then, but they've gotten much cheaper over time. So the short answer is that if you just treat people with the best drug for 7 days, that's about 80% accurate in predicting whether you have reflux or not. So if you say, well, gee, how do I know if I have reflux? Well, if you want, you can go down to the store, pick up a box of Prilosec OTC, and it's over the counter. It doesn't require a prescription. You could try it for 7 days. And if you notice that you are much better, okay, that's probably about 80% accurate, okay? And it turns out that when you asked, when you tried these two approaches, should I start with the best thing first or start slow and work my way up? As you'd expect, when you do the best thing first, people tend to be symptom-free. More than half of the people were completely much better in 2 weeks. Whereas if you started with the lower stuff, it took them 8 weeks and only half of them got better at that point, okay, or completely. So the costs were about equal, but obviously patients like doing the best thing first, understandably, okay? And you might say, well, gee, if you're using the most expensive thing first, how come that wasn't more expensive? It's because the longer you don't get better, the more you visit your doctor, right? So that leads to more office visits, more other things. So you might save money on the drug, but you then you spend a lot of money on doctor visits, okay? So the bottom line is, and this just goes back to this, I just want you to remember one thing about this slide. The drug that we take, this PPI medication, only works on blocking these pumps that I told you about when they're active, okay? So it doesn't work when they're not active. So the question is, well, how do you activate the pump? Well, you have to either eat or think about food, okay? So imagine these things as sort of heat-seeking missiles or something that, are only going to activate this when they're on. So if you're not thinking about food or eating, these are off. This just goes into your bloodstream, it circles around for a while, and then it says, well, I never saw any active pumps, and then you just excrete it, which usually means it goes out through your urine. So the most common mistake people make is they take this medicine on an empty stomach, okay? So if you take this medicine and you don't eat for within an hour, basically for the most part, most of them, with slight exceptions, for the most part, it's going to do very little to nothing, okay? So some people say, oh, doctor, I take it every night. I take it right before I go to bed. Well, okay, it probably works just as well if you deposit it in the sink, okay? So it's really important to take it with 15 to 30 minutes before a meal. That's the ideal time. Not right when you're sticking your fork in the food, but about 15 to 30 minutes, okay? So there it is right there. So this is the most important thing I'm going to tell you, okay, is if you're going to be on these PPI medicines, make sure you take them 15 to 30 minutes before you eat, and make sure you take them every day. Don't what we call PRN dose, which means take it as needed. And the reason is, if you take it one day, you block all the acid, and then what your body does is it says, there's no acid in here, so I'm going to jack up the levels of all these other hormones that make acid because maybe my body isn't making enough. And then the next day, you don't take it, and I told you that you make new pumps every day. So now you have this really high level of this hormone saying make acid because yesterday there was no acid. And today you don't block it. So what do you think happens to your acid the next day? Boom, way up high. Okay? And now you're like, oh, I feel terrible. Then you take it again. Then you feel better for a day. Then I say, well, I feel good. I'm not going to take it today. And then goes up. And then you're on this sort of roller coaster ride. You're up, you're down, you're up, you're down. So if you're going to do this, you really should take it every day. Okay? If you have a problem taking pills, you can dissolve it in apple juice. You can put it in granules in applesauce, other things. There's a variety of ways that you can take it. So it's interesting because, again, this was a physician who, it was about 10 years ago, he looked at 100 people who came into his office. He's a GI doctor, and he said, tell me when you take your medicine. And what he found out was only about 46% of patients took the medicines even somewhat close to when they should, which is within an hour before a meal. And only 12% took it at the maximally effective time, which is at 15 to 30 minutes, okay? You see all these people here took it at bedtime, this big section of the pie. That's basically useless, okay? Some people took it as needed, which we don't recommend. And all these people here took it after meals, which is also not as good, okay? So all the people on this section of the pie here were taking it rather poorly, and that's part of the reason why they were seeing the doctor, because they weren't taking their meds right. So I'm not here to get into which drug to use. The short answer is they're all working about the same. It's a huge market. This is the most profitable class of medications in the world, and they're most widely used. There's a whole bunch of different ones here, and I'm not here to endorse or refute any of the others. Your insurer will often have one that it likes. There's actually even more than this now, but these are some of the common ones, okay? So one thing that a lot of people will hear about is they say, well, I take this medication, but I'm good during the day, but I still have problems at night. And so there was some thought that, at night you're lying down, you don't have gravity, you're not eating, so you have less sweeping of the esophagus. You don't make as much saliva at night because you're asleep. During the day we're talking more, we make more saliva, so there's less neutralization. And so the theory was that there was more acid exposure at night. And there was some data to suggest that there were certain medications like Zantac at bedtime, if you took it, would actually help. How many of you take something called Zantac or Tagamet or anything at bedtime? Have your doctors? Anybody doing that? Good. Okay, because it doesn't work. Okay, so I'm glad. So, all right. So that's good. So it turned out there was for a while a lot of people said, well, the way to solve that problem is to do that. But it turns out that doesn't really work, and the effect lasted less than a month. So if you're having symptoms at night, if you're only taking it once a day, you should maybe take it twice a day, or switch your dose to before dinner rather than before breakfast. Okay. So. And if you have symptoms during the day that you need to take it for as well, then you might need to take twice a day. And about 10 or 15% of people will need to take twice a day in order to get their symptoms under full control. Okay, so if medicines don't help you, what if you say, well, gee, I took it the right way, I'm doing it every day, I'm doing it twice a day? Well, you might have a different diagnosis. And so this is the part that I said, is it heartburn or is it something else? Well, here's the something else, okay? So one of the things at that point, usually, if you're on these medicines and you're not resolving, you're in probably 10 or 15% of the population. And that's usually time for when you should see your doctor and probably see a gastroenterologist and probably get an endoscopy, okay? And so at that point, we'll look to see if there's inflammation or not. If there's inflammation, it could be from a pill, it could be from a skin disease, it could be a condition called eosinophilic esophagitis, which is some people call asthma of the esophagus. If there's no esophagitis, you could be having nighttime breakthrough. It could be another diagnosis. It could be very subtle reflux that just isn't being caught yet. Or it could be another issue like heartburn, functional heartburn, which is really almost like a neurologic problem where the nerves are sort of telling you that there's something going on when there's really nothing. Almost like a phantom type pain. Achalasia, which is a motility disorder, or gastroparesis, delayed emptying. So I'm not going to go into each of those other things, but those are the things that's why you're going to the doctor for. They're there to figure that stuff out if you're not responding. So how do we test for this? So I told you, you're probably going to start with these symptoms. You're going to start with medicines. If it works, great. You've probably got your answer. If it doesn't work or you have certain symptoms, that's when you need to get tested. So we have a couple of tests. We can look directly, or we can use something called a pH study. The pH study is, there's now sort of more very friendly wireless techniques to do this. So in the old days, the way you used to do this was we used to put a little tube in your nose and it would go down into your stomach and you'd have to walk around all day with this thing in your nose while it was measuring the acid. And then we'd tell you, okay, well, go home and act normal. And of course, it's hard to do or eat when you're, got this tube in your nose, right? So now we actually have this little device. If you can see a quarter next to it, we actually attach it right into the esophagus, okay? And it's there for now. It can be up there for up to 4 days, okay? And it can measure. We can even do you on medicines, off medicines. We can do all kinds of things. And we can see just how much acid is going up there. And then you can keep a log of your symptoms, and then we can tell you, yeah, you have acid, but it's not when you say you have it. So we can not only tell you if you're having acid coming up, but whether it actually correlates in time to the symptoms you're having, right? So the perfect would be, yes, you're having reflux, and it's exactly occurring at the times you say you're feeling bad. That's what we like to see. But it could also be that maybe you don't have reflux and what you have is something else, okay, because there's no acid. Or it could be that you're having reflux, but it's at a time that's completely different from when you're having symptoms. And so it may be that there may be two things going on, okay? So we can test it with this device, and it'll give us sort of the pH at the top of the esophagus, or lower. This is more from the old tubes, but we can see when there's an episode of reflux, the pH, which is normally in the esophagus about 7, is going to drop down to about 1, and anything under 4 is abnormal. Okay, so this tells us how much you reflux, when you reflux, whether you do it upright, when you do it lying, how many times it occurs, how long each episode is, and how well it correlates to your symptoms. So we can get a lot of information about what's going on, and that can help us determine what the best solution might be. Okay? Like I said, you can already do a trial of medications, but most of the time that's what we do first. And then you can also do endoscopy. Okay? And so one of the questions is, well, how do I know if I need an endoscopy? Okay? Because that seems kind of invasive. Maybe I don't really want to do that. Maybe when do I need to? So these are some of the symptoms: weight loss, dysphagia, which is trouble swallowing, bleeding, if you're vomiting up blood or you notice blood in your stools, if you're having a lot of chest pain, if you're having choking symptoms. And again, the two main things that sort of chronic reflux can cause is it can cause ulceration, which can lead to bleeding and anemia, or scarring, which can then close the tube down and lead to a narrowing of the tube, which makes it more difficult to swallow food. So you'll see food get stuck, particularly things like meat and bread. That's sort of the first things that people will notice. So if you'd say, oh, I tried to eat a hot dog, I had a real hard time, that's sort of the perfect sort of stress test for your narrowed esophagus, is sort of a combination like that. And then Barrett's esophagus, which is basically when you have chronic reflux, your body wants to protect itself. And you work hard with your hands, you get a callus. If your esophagus gets a lot of acid, which it's not supposed to see, your stomach is prepared for acid. It's got a special lining to protect it for acid. Your esophagus doesn't. The lining of your esophagus is a little bit like the lining in our skin. It's really not meant to see that much acid because that valve is supposed to protect it. When it doesn't do its job and you get a lot of exposure, the esophagus changes its lining to become more similar to that of the stomach and intestine. And when it does that, it changes color. And there's this guy named Norman Barrett. I'll talk about him a little bit later. He's a surgeon. He first noticed this and said, boy, I see this in a lot of my patients with reflux. And he said, maybe this is related. That's why we call it Barrett's esophagus. The reason we care is because it increases your risk for developing esophageal cancer, which is one of the worst cancers you can get. Okay? So these are the indications for endoscopy. And I know this well because these are the national guidelines that I wrote. So I better know this. So the main things are, again, reflux symptoms that are they continue despite taking medications. If you have trouble swallowing, involuntary weight loss, if you're having more than 5%, evidence of GI bleeding or anemia, finding of a mass or stricture on another study. Again, screening for Barrett's, and I'll tell you who might be screened. You might say, well, gee, I wonder if I have Barrett's, and we'll talk about how to screen for that. If you have persistent vomiting, if you're having consideration of an anti-reflux procedure, usually they'll want an endoscopy for that. And the last thing is, of course, I showed you that much nicer way of checking the pH, but we do that through an endoscope. So if you're getting that pH study done, you'd need that endoscopically. So So what happens when you get inflammation? Interestingly, the system that we use worldwide is actually called the Los Angeles classification, and it basically breaks it up in different ways. And this is more doctor talk than anything else. But you can see this is a milder case where you see these little white lines are actually the ulcers and inflammation. And then here's a more severe case where it's just kind of all the way around. And that's a worse case. And again, you can see actually here, if you can see the opening here is from here to here, but here you see this little pinhole is right here. See that? So that's actually what I meant by developing a stricture. So this is an example of what happens when you get this for a long time. So how do you treat this? Well, you treat it with those medicines I told you about, usually twice a day for 8 weeks, and it's important to document that it's healed, because if it hasn't healed, the conditions that I told you about, the worried about the stricture, the bleeding, the anemia, and potentially development of Barrett's can occur. So it's really important for us to not only know that you had it, but to also know that after medications that it went away, okay? The only reason in general do you need to do another healing with another endoscopy, most of the patients who have symptoms will have a healed endoscopy, a healed esophagus when you rescope them. So in other words, if you say that, doctor, I feel great, all my symptoms went away after you gave me that medicine for 8 weeks, 95% of the time when we look again, everything will be fine. But there are a few times if either your symptoms don't resolve, or if there was some concern that you might have a cancer at the time of the original endoscopy, or if we really were suspicious that there was some Barrett's, we should probably take a look again. Okay, so those are the times we look again. So the other group of people, you might say, well, gee, my medicines are working fine, I don't have any problems, but I just wonder if I have Barrett's. And so how would I know if I have Barrett's or not? And the short answer is, we don't know for sure, but we know that most of the time it's white men who are having symptoms for many years, particularly at night. Usually they may have a hernia, they're often a little heavier, maybe they smoke, and in particular they have a belly distribution of fat. And it's really if you have multiple of these things. If you say, well, gee, I'm a guy, but I'm Asian and I'm 35, that doesn't mean you should probably get scoped, okay? You should have several of these things, okay? And it's not that women can't get this, but most of the time, about 80% of the patients, or 80 to 85%, are men. So a friend of mine has a joke, where he says, a man brings his wife to the doctor's office and says, I'm really worried about my wife. She's got reflux, and I really want you to do something about her. And he asks the doctors in the audience, what should we do? And the correct answer is scope the husband, because the short answer is that just by being male, he's got more likelihood of having Barrett's than his wife, even though she's the one symptomatic. So this is what Barrett's looks like. It's this pink lining of the esophagus. This is using our high definition imaging. You can see these little glands that develop within the Barrett's, okay? Here's an example of high definition imaging, and here's a nodule, and this is actually what an early cancer looks like, okay? So this patient's developing esophageal cancer as a result of chronic reflux arising from Barrett's esophagus, okay? So what if you say, well, yeah, I want to get tested, but boy, I really don't want to do an endoscopy. We're working on ways that we can develop that you wouldn't have to do an endoscopy. This is a very novel device. We're one of 4 sites in the country that actually have this right now. That's a pill that you basically is attached on a string. You just sort of come in, you swallow it, it'll go down into your stomach. We wait 7 minutes. The capsule dissolves and it becomes this sort of Brillo pad here. And then we basically pull it out. It scrapes off the cells in your esophagus, kind of like a biopsy, but without the endoscopy. We send it over to the lab, just like you would a blood test. And a couple of days later, we find out if we think the test is positive for Barrett's or not. And then if it's negative, it's pretty accurate. It's only about 5 in 100 people in whom it says that it's negative will actually be found later on to have Barrett's. And it catches about 90% of the people who actually do have Barrett's using this. So this isn't, we're doing this study as part of a trial. If any of you are interested, you're certainly welcome to come talk to me afterwards and we can talk about what we do. It's not ready to stand alone at this time. But I hope in 5 years that, if you want to check for Barrett's, you could go to your primary care doctor's office and they could do this for you. And then only if this was positive would you get an endoscopy. Okay, So in the last 15 minutes, I'm going to just talk a little bit about surgical and endoscopic treatment options. Surgery for heartburn. Again, heartburn's well controlled, but regurgitation continues. You can be, again, intolerant to certain medications. Maybe, that's another reason. Or the medications work, but you just don't want to take medicines. So the real reason is you hate taking medicines, you can't tolerate the medicines because of side effects, or because, when we treat heartburn with these medicines, what we're doing is we're just making what comes up less irritating. So it's like saying, I just don't like getting wet, okay? If you say that, you can imagine acid reflux is like getting splashed with hot water. And all we do when we give you these medicines is we make the hot water like lukewarm water, but you're still wet, okay? If you want to stay dry and not actually get this stuff coming up in the esophagus, you often will need to do something to mechanically fix that barrier, okay? And that's what a surgery does, okay? So if regurgitation is not your problem and it's just a heartburn, you may be fine with medicines, but if you have a lot of regurgitation, you may need that. So the first surgery was done by over 100 years ago by fixing a hiatal hernia, by bringing the stomach back down into the abdomen from the chest. Many of you may have heard of something called a Nissen fundoplication. It's the name of the surgery that's most commonly done to treat reflux. That was first done about a little over 60 years ago now. Again, then we sort of learned how to do this Nissen laparoscopically, through little portholes, not through cutting open the whole abdomen or chest. So now when you do this procedure, it's basically an overnight stay. So you come in on Friday morning, have your surgery, you should be out by Saturday afternoon, okay, if things go right. There were some studies that showed that it worked 90% of the time for 5 years, but then a study from the VA suggested that it didn't actually work, quite as well. So before you get a surgery, you need an endoscopy, that pH study, a little test to make sure that your esophagus functions right, and usually they make you take an X-ray study to look at your esophagus, okay? And what they do is they make a bunch of little portholes, and they take your stomach, and they take the upper part of the stomach, and they wrap it around the bottom of the esophagus, kind of like a purse string, and then they sort of suture that up. And so the esophagus almost, is wrapped around by the top of the stomach. And so it's called the fundus of the stomach, and you plicate it, so that's why it's called a fundoplication. Okay? 90% of people go home in a day, and most people are back to their normal lives in 1 to 2 weeks. It does cost money. You need anesthesia, you're out, it's general anesthesia. And the most common complaint is people say, oh, you tied it too tight. I have a hard time swallowing now, okay? Or, people say, oh, I used to belch all the time, now I can't belch. So careful what you wish for. The valve's loose, it tends to be easy. But then now it's tight, and you feel like what it's tight, you say, oh, now I can't get the gas out, I don't like that either, okay? So that's called gas bloat. That happens in as many as half of the patients. So this is the study. There was a study that was done in the VA many years ago, and I'll sort of cut to the chase, which said that even if you did the surgery, though, that 60% of the patients would be back on medicines, during follow-up over about 5 to 10 years. So there was that point, and a lot of people were like, well, gee, why would I do the surgery if I'm going to be back where I am in 5 years? It doesn't seem like it's worth it. But that was really looking at some patients at the very beginning of the procedure. A surgeon sort of challenged that. Actually, it's interesting. You always know sort of who did what based on, the nature. So the person who said the surgery was bad was a gastroenterologist, and the person who did this study that said surgery was good turned out to be a surgeon. So this was a surgical study that was done looking at medicines compared to surgery, and found that it was a randomized trial, 7 years. And what it found out is that the surgery arm was actually as good or better than the medicine arm. And certainly surgery now, I must say, this is a pretty effective surgery. It is pretty durable, okay? There are some endoscopic techniques. I'm not going to talk about them for the interest of time. There are some things that are out there. There are also some new surgical things like LINX, which is putting a magnet around the bottom of the esophagus. We do that here at UCLA in case you want a different kind of surgery than the fundoplication. There are some other new things that come out. There's a new, like a little pacemaker that they basically plant an electrode, and just like turning a thermostat, it's like I'm a little hot, I'm a little cold. I'm going to dial up my electrical stimulation to sort of pinch this thing a little tighter, or maybe I'll dial it down a little bit, So that's called EndoStim, and that's not available yet in the US, but it should be coming soon. Okay. Ironically, the people who respond best to surgery are the ones whose medicines already work, okay? So the take home is, if my medicines don't work, the surgery's probably not going to help me either. Okay? So it's really for people whose medicines work and they just don't like taking the medicines, or they have an intolerance to it. Because a lot of times the reason the medicines aren't working is that your problem is not reflux to begin with. Okay? It may be another diagnosis, which goes back to the title of our talk, which is it heartburn or something else? Okay? So make sure you confirm the diagnosis of GERD and discuss the likelihood of success and what the pros and cons are. I think that's very important. Okay. Last 5-10 minutes I'm going to talk about is this guy, Mr. Norman Barrett. Does anybody know why we call him Mr.? Because in England, they call surgeons misters. They're not, so medical doctors or internists are doctors, but surgeons are called misters. Okay, so he was a British thoracic surgeon who noticed that he was noticing that when he operated on people with hiatal hernias, they were all short esophagus, they were all up in their chest. He always saw this sort of funny lining at the distal esophagus, the bottom of the food pipe, and he noticed a change in color and he named it. So it sort of has this salmon-colored appearance to it, and so that's what we call Barrett's. Barrett's is probably present in at least 1% of the U.S. population, but there's now some studies suggest it may be as much as 3 or 4%, which means it's at least 3 million, but it might be as much as 9 to 12 million, okay?
Is it always malignant?
No. In fact, in most cases, it turns out not to be malignant or develop into malignancy, but it can. And I'm going to go into a little bit about that in the next 5 minutes. Yeah, that's a good question. So we know that certain populations are more likely to have Barrett's. I told you the joke about the men, and we know that people with reflux are more likely to have it. That's why we tend to screen them a little bit more. But if you find out that at a VA where the patients are obviously predominantly men, even if regardless if they had symptoms or not, they just came in to get their colon cancer screening. They said, hey, by the way, do you mind if we just take a look from above? And they found that 1 in 4 patients had Barrett's when they did that, okay? So again, it's much more common in men, particularly white men who are older. So again, probably at least 3 million Americans have Barrett's, but I think that's probably on the low side, okay? And that's equivalent to the population of those 3 states combined, which probably just tells you how few people live in those states, which I can say because I used to live in South Dakota years ago. So, okay. So why is it important? Because it's abnormal tissue. It's precancerous tissue. It makes your risk for developing cancer of the esophagus as high as 40 times as high as if you didn't have it. And patients who have Barrett's are obviously kind of anxious about it because they know they have a precancerous condition. And they want to know, is there something I can do about it, or how much they should be worried. So esophageal cancer worldwide is a bad disease. You see that 529,000 people get it a year and 442,000 die of it. So it's not something that there's a lot of success stories on, unfortunately, okay? Most of the patients have advanced disease or it's already spread when they get diagnosed. And what are your chances if you have esophageal cancer? It's about 1 in 6 to 1 in 10 that you'll live 5 years once you get it, okay? So we'd like to prevent it. We'd like to catch it sooner. That's part of the reason we're interested in sort of trying to find these patients earlier. And, the incidence of what we see is there's really 2 kinds of esophageal cancer. There's one associated with smoking and drinking, and that's what we see sort of in more of the developing world. We see that in Asia. We see that more in Africa. And then we see a different kind of cancer in patients who are in the Western world. And those patients tend to have this adenocarcinoma, and that's really been increasing a lot in the Western world, United States, Netherlands, Europe, Australia. These are the places we tend to see that the most, is really Europe, Australia, and North America. And there's very high rates of this. And we see the biggest jumps are occurring in these areas, so as these areas get industrialized. So. And this type of cancer, Barrett's esophagus adenocarcinoma, is more associated with reflux, which is often tied to obesity, okay? So in the United States, we've done a good job in a lot of areas. Colon cancer screening and everything has really helped. Colon cancer rates have dropped over the last 30 years, 40 years. But you see this one pink line that's just going crazy, and that's esophageal adenocarcinoma. So we haven't done a good job with that. Why is that happening? Are we finding more people because we scope more people? Are we just getting heavier as a country and we all have more reflux? It's not exactly clear, but while we've made a lot of success or held the ground in a lot of areas, this area has kind of gotten away from us. okay? And this occurs again because of chronic inflammation leads to changes in the esophagus to Barrett's, which then over time progresses to low grade, high grade, and cancer. But not everybody, that we'll go over. Basically, the chance if you have Barrett's that you'll develop cancer in your life is between 5 and 8%, okay? So the question is, how do I figure out if I'm in the 5 to 8%, right? That's what everybody wants to know. Stay tuned, we're still working on that, okay? Right now we have to kind of just keep an eye on you at various levels, and then if you start getting sort of in these areas here, we now have a very effective way to treat you. So the good news I can tell you is, 15 years ago I would have just told you, well, I don't have anything to give you, we're just going to watch you until you develop cancer and then we'll take your esophagus out. And that's literally what we told people. Now we basically like, well, we have a treatment that can get rid of it 90% of the time. It's just a matter of figuring out if you need it or not, okay? And so that's the nice thing. So we don't need to treat everybody, but we definitely have options should you start moving down this pathway, okay? So again, this is Barrett's, and you can see the cells get more crowded and more abnormal and more disorganized. So this is Barrett's, this is low grade, this is even worse, this is high grade, and that's cancer. So the cells get more disorganized. And again, you can treat with medications, we can take biopsies, we can do something called mucosal resection or ablation, but not surgery. No surgery is going to protect you from Barrett's other than if you just take your esophagus out. But a lot of people will say, oh, anti-reflux surgery will cure your Barrett's. No, it won't. There's no good data for that. So if anybody tells you that, that's not accurate. Okay. The problem, what we do right now is we just take biopsies every few years and then we say, okay, it looks good, come back again. It's like sampling the esophagus. We just, so the problem is when we take the biopsies, we're only sampling about 3 to 5%. So if there was a room with 100 people and I'm only going to ask the first 5 people, what do you think? And I said, I know what y'all think based on these 5 people. You might say, well, I don't know if that's true. There's 95 of us you haven't asked, right? So, and that's part of the problem when you do Barrett sampling is that, you're only sampling a small amount and there may be areas that you miss. And then if you don't come back for several years, something could develop, okay? And your doctors, unfortunately, they're supposed to take a certain number of biopsies. The short answer is that they only do that about half the time. And the worst thing is the bigger the haystack, they're supposed to take more straws, but they don't. So essentially, the people with the biggest haystacks get the fewest straws drawn, which makes you even more concerned that there could be something missed, okay? We do have ways, as I mentioned, I'm going to wrap up in the next 2 minutes here, but these are some of the techniques that we have. We have the ability to inject underneath, these lesions, lumps and bumps. We can cut them out. We have caps. We have a whole bunch of different ways. We can basically almost do endoscopic surgery. Here's a patient who had dysplasia in a nodule. See this little pink stuff here? This is that Barrett's. See how it looks lumpy and bumpy here? That's abnormal. And basically, in 5 minutes, we can just cut that out. Okay, so we have techniques that we have to do that now. This is a patient who had a whole bunch of Barrett's that we treated with ablation. We can actually burn off the tissue and get rid of it. And the way we do that is we take a balloon, we measure the size of your esophagus, then we subsequently take a little treatment. We just burn off the surface layer, we scrape off the dead tissue and repeat it again. And then we wait about 2 months and we keep doing it until it's gone. It usually takes between 2 and 3 sessions to do that. This is a study that was actually published in the top medical journal in the world, the New England Journal of Medicine, about 6 years ago, showing that 90% of patients could get rid of their dysplasia and about 80% could get rid of all of their Barrett's using this technique. So it's quite effective. There are other techniques you can use. You can also freeze it. You don't have to burn it. You can freeze it. The data on the freezing is not nearly as compelling or as broad as it is for the burning, but we do have more than one option. And here's a patient who actually had a cancer that was frozen and actually responded to a freezing technique. They're used for slightly different indications. So in summary, where do we think Barrett's will end up? Well, we hope is that someday you'll be able to just go to your doctor's office. If you think you have it, you'll do something like that sponge. If the sponge is negative, they'll say, good day, go on your way. If it's positive, they would refer you to a gastroenterologist, and only then would you get an endoscopy where we would either confirm that it was there or figure out if it was a false positive. If it's a false positive, you're done. If it's present, we'd hopefully be able to come up with some way to figure out if you were in the 5 to 8% that were going to go on to get cancer in your lifetime, or if you were in, the majority that aren't. And if we could tell you that reliably, if you weren't, then we'd say, don't worry about it. And if we knew you were, we'd treat you. And if we were like, we're not sure, we could do something in between, maybe give you certain medicines to hopefully prevent the development of cancer. The problem is it all depends on figuring out how to figure out which group you're in, and the problem is we don't know how to do that yet, okay? So in the meantime, we're sort of stuck, trying to just either figure out, should we watch this person or should we treat them? That's a little bit based on how old you are, how much Barrett's you have, how much dysplasia is present, how abnormal the cells are in the Barrett's, and so forth. So in summary, we know that medical therapy for reflux is highly effective. It's very important to take the medicines right, 15 to 30 minutes before breakfast and dinner, or either or if you're taking it once a day. Extraesophageal symptoms are frequent and underdiagnosed, so if you've got asthma, bronchitis, a hoarse voice, sore throat, don't forget that it could be reflux, and maybe treating your reflux might help some of those symptoms, particularly if they can't figure another cause. We have a lot of tests that we can do in addition to just a trial of medications. We can measure the pH in your esophagus in great detail. We can do endoscopy. I kind of showed you when you should reserve your endoscopy. Most people do not need endoscopy. It's really only a small fraction of people with reflux that need endoscopy, and we went over who those are. And likewise, screening for Barrett's, really you should have multiple risk factors before we do that. I wouldn't do surgery unless you just were intolerant of the medicines or really didn't like taking medicine. And just remember, the person who responds best to surgery is the one who's doing really good on medicines, okay? So if you're not happy with your medicines, surgery doesn't always fix it. You may have the wrong disease, to make sure you check that. And we talked a little bit about Barrett's and that we have effective treatments, and it's just in figuring out when to apply them. So again, I thank you for your attention, and I will take any questions that you have on this, okay?
Isn't there a predisposition in certain families for acid reflux?
I don't think that there's familial reflux. I mean, reflux is so common. Certainly based on the way people eat, so much of this is based on your diet. Families may eat together. Obviously, they cook meals together. They may tend to be heavy together. So those things may end up together. But there isn't a gene defect that suggests reflux or anything like that. And a small number of people, there is a small percentage of people who may have familial Barrett's. But again, that's even a small portion. So, if reflux runs in your family, it's probably more based on what you're eating and how you live. Maybe you're not as active, maybe other issues, maybe you eat late at night, more related to your behavioral things rather than your genetic predisposition. So, okay. Yes, sir.
You were talking about when acid starts going in your body and you take acid down.
Mm-hmm.
Where does the acid go that's been controlled?
So two things. So good question. So if you're taking an antacid, it's basically like pouring hot and cold. So it's neutralizing it. So you have acid and base, and boom, it neutralizes. So it's just like, where does the hot water go? It's still there. It's just got neutralized by the cold water. That's why antacids work so fast, because they work on contact. Okay, they're not that strong, but they do work right away. The medicines that I'm talking about, like these PPIs, they take a while. Okay, the minute you take a PPI, it doesn't do anything. It has to get absorbed. It has to go in the bloodstream. You've got to eat. Then it's got to go block that pump. And then several hours later, when that pump should be making acid and it's not, that's when you catch up. So the acid doesn't really go away. Well, the acid that was made ends up going downstream and neutralizing your small bowel. But the problem is you don't make any new acid, and that's how you catch up. But that's why it takes a day to do it. So if you're saying, oh, my esophagus is on fire, I'm going to take my purple pill right now and I'm going to feel good in 10 minutes. No, you're not, okay? Because the medicine's not going to work that fast, okay? Yes.
What the long-term use of the PPIs, are there any risks with that?
Yeah. There are some conditions that, it can hurt calcium absorption. So if you are at risk for having osteopenia or osteoporosis, it might hurt with that. It's increased the risk of certain fractures of bones, wrist and vertebral fractures and so forth. It may increase your risk for certain infections, both of the lung as well as within the GI tract. And it can impair the absorption of certain blood thinner medications. So if you're a patient who is a heart patient, a stroke patient, and you're on certain blood thinners, you need to talk with your doctors about whether you can take this medicine safely. Many of us are skeptical about some of that data in terms of how risky it is, but nevertheless, there is an FDA warning and we have to abide by that. So if you're on certain medications, antiplatelet medications, you have to be careful about whether you can take those medicines with this medication or if you need to switch to something else. Okay, so.
What happens
Huh?
if you have scleroderma?
Scleroderma is one of the conditions that it was on my list early on about conditions that are physical conditions. So scleroderma is a condition where the esophagus, the muscle, doesn't really work. It's kind of just like a stiff pipe. And so the problem is the muscle doesn't squeeze, and then if you do get backwash, the esophagus doesn't do that sweeping motion. So it's more likely for stuff to come back up, and once it's up there, it takes longer for it to get cleared out. So you get a lot of symptoms from that. So, and that is a big risk factor for reflux and esophagitis and a lot of those symptoms. So you do have, if you have scleroderma, you do have a big risk, increased risk to develop reflux symptoms. That's right. So, get you there, ma'am?
You did not mention Dexalant.
Yes, that's why I said that, not every drug is on there, but Dexalant is the one that is advertised to be less dependent upon when you take it in terms of timing. So I told you this whole business about, you got to take it 15 to 30 minutes. Dexalant is sort of advertised as being less sensitive to that. That is, you can be a little bit more relaxed about it and it'll still work.
This for 20 years. I've tried Prevacid or anything. Which one is that affects 12 hours? Which one is 24 hours?
Well, most of the PPI medications will have some degradation, in the second half of the day. They're typically meant to be once a day, but the level in the blood during the second 12 hours starts dropping. And so that's why some people need a second dose to keep that at a high level. Most people can get by with just one, but that's why I said about 10 to 15% do need twice a day because it does start tailing off. They're intended to be about a once a day drug, 24 hours, but they do start dropping in the second 12. So
the Dexalant affects 12 hours, so I did switch to Dexalant.
Yeah. The Dexalant's thing is that it's got this it's buffered so that it sort of releases over a longer period of time, and so you can still get some effect even if you take it after a meal or with a meal. It seems to be a little bit less dependent. That's what it's advertised. In clinical practice, I'm not so sure that that's what I've seen, but that is theoretically what's different about this drug than the other six, right? That's the. Yeah. Go ahead.
Yeah, my dad used to have his esophagus periodically stretched. Is that something they still do, or?
Yeah, sometimes we can dilate it. He developed a stricture, it sounds like, and that's from one of the complications we talked about from chronic reflux. I showed you that inflamed thing with the little pinhole, and that's what often develops, and then we have to dilate those, and usually we can manage those pretty well, but it sometimes does require several sessions to do that, and may require some intermittent touch-ups to keep it open. So I have many patients like that in my practice that I have to do that for. So
it's still in
oh yes, absolutely. Yeah, absolutely. So
When the gastroenterologist does the endoscopy, they take a biopsy and they look and see, they can test for Barrett's at that time.
correct. You can right, and you make a great point, and you use the word biopsy because you can suspect it visually. I can show you those pictures and say, I see that salmon-colored tissue you told me about. But in the United States, the diagnosis is made by what you see under the microscope. So you can suspect it visually, but you must confirm it under the microscope before you can call it truly Barrett's. That's why your doctors will say, usually they should say, well, I think you might have Barrett's, but I have to wait for the biopsies to come back, okay? And so that's what they should be telling you because you have to confirm it with the biopsies. Correct. Yep, there's a lot we can, yes. Yes, I think you had a question, sir?
You can treat the inflamed esophagus while you're doing the endoscopy?
The inflamed esophagus, no, that's something that's going to require healing by controlling the acid. So that's really done with medical therapy. What we can do, though, is We can treat scar if by dilating it, as you mentioned, you can dilate that. Or as I mentioned, you can either burn off, freeze off, or cut out the abnormal tissue. And so we have techniques to do those things, but we can't heal inflammation with the scope.
What do you use to burn or?
You're right. I showed a balloon device that you can. This is the treatment catheter. So this right here. So this is called radiofrequency ablation. So that's one of the techniques that we use to treat this. And that's the best studied technique. Yes, sir.
Controlling acidity, PPIs, as well as maybe diet or two techniques. How about probiotics or anything else that?
Yeah, probiotics have been really helpful with a lot of things related to digestion and gas and maybe bowel frequency. It doesn't appear that it plays such a role in the upper GI tract, because in this area here is relatively devoid of bacteria. So we know our colon is full of bacteria. Our small bowel is supposed to be relatively low in bacteria, but based on certain characteristics, you might have small bowel bacterial overgrowth, which could cause some. But the stomach is usually, because of the acid, is usually pretty devoid of bacteria. There's one notable exception, which is this thing called H. pylori, which is the bug that actually is associated with developing ulcers. And we used to think ulcers were primarily due to too much acid, but a doctor in Australia found out that, in fact, it's actually probably an infectious disease, and that most people actually have this bug, and if you just treat them for 2 weeks, their chance of getting follow-up ulcers is much less. So that was really a landmark discovery in medicine. So, yep. Yes, sir.
Is it possible to come off PPIs? And also, does the LES ever regain function?
The LES usually, I wouldn't think, regains function. It is what it is. It's usually, there's not anything you can do to per se strengthen it, through exercise or diet or anything. The only thing I would say is if you're taking a bunch of medicines or drinking alcohol or doing a lot of things that can lower the LES pressure, stopping those things may help bulk it up. So if you say, well, I'm on a calcium channel blocker that's known to lower the LES, if you switch to a different kind of blood pressure medicine, it could strengthen for the reason that you're not weakening it with that medicine anymore, right? But if it's not being weakened by anything that you're eating or ingesting, it probably doesn't spontaneously go. Now, in terms of can you get off the medicines, absolutely. But just realize that most people, I showed you 2 pictures of 2 men early on in my talk. One is the sporadic heartburn, the person who, I ate bad last night, and then the other person has it every day. And for the majority of people, what I tell people is reflux is a chronic disease for most people, like high blood pressure, diabetes, cholesterol. And it's really something that requires daily management. For some people, it's just a now and then thing, and they may be able to get by with an antacid here and there. So it's certainly worth a trial of medicines, and then at some point when you've been feeling great for a great time, you could stop. But if it comes back, don't be shocked or disappointed. You're just someone who probably needs to make the medicine long term. But there's certainly a lot of people who have been put on a medicine and they just are on it forever and never tried stopping it. And so it is good to at least try it once, but I'm just saying that a good number of people will fail that and have to go back on the medicine. Okay?
Did you say that if you started one of those medicines that in 2 weeks you should feel better, and if you're not feeling
The majority of people will feel better within 2 weeks. It may not entirely be gone, but if you feel nothing after taking it every day for 2 weeks, then maybe we should start entertaining other possibilities. Okay, it's a highly effective medicine, particularly at the twice-a-day dose. Maybe if you were on once a day and you said, Doc, I don't feel anything, I'd say, okay, well, let's maybe try twice a day. And then if at twice a day you're taking it every day and you're not feeling anything, then maybe you're in a very, very small group that has a very high production of acid, which is very rare, or maybe we're dealing with something else. Okay. One last question.
You mentioned that people have a hard time taking the medication correctly.
Yes.
One of the challenges for me is, I'm cooking, I've got things going on, and I never know what 15 minutes is before I'm going to eat.
Yeah, usually, well, I tell them when you go out to a restaurant, pop the pill when they bring in the water. Okay, that's when you're out. When you're cooking, I don't know exactly what your ritual is in terms of how you're going to do it, but 15 to 30 minutes. So, depends on how long it takes you to cook. If you're wrapping it up, then maybe that'll be individualized. So I think, but you ideally would like to take it. Nobody can get it exactly right, and I'm not saying you need to have it down to a timer, but 15 minutes to an hour is the ideal. If you do it less than 15 minutes, it's too close. You won't get the full. If you do more than an hour, the drug levels will start coming down a little bit. Okay? All right. Okay. One last question, and then I'll stop there.
You take a PPI, I take it once a day.
Yes.
But sometimes at night, it's still, the acid reflux still bothers me. Would it be better to take this like 15 minutes before dinner?
Yes.
And work through the night?
Correct. And then if you say, now I'm good at night, but now I have problems during the day, now you need 2 times a day. But, your daytime, you're helped with one thing, you're standing up, right? So it's maybe better for you to switch to night before dinner, and then if that doesn't work, then you need probably 2 a day. Okay? All right, well, thank you all for coming out tonight. Appreciate your time, okay?